your nursing homes and things like that, although a lot of skilled nursing facilities do offer some quality rehab programs, but the level of care that they offer and the level of the rehab programs that they're offering is um, greatly deviates from what like an LTAC would offer or what an inpatient rehab hospital would offer. So over on the right again, you have inpatient acute rehab hospitals, sometimes called IPRs or IRHs, or as a lot of people call them, IRFs. Regardless, it's inpatient rehab hospital. They're licensed as hospitals. Then you have your specialty care centers. Specialty care centers have a very narrow scope of practice and will typically focus on something like traumatic brain injuries or spinal cord injuries. Then you have your assisted living facilities and extended care facilities. So, assisted living facilities can be your traditional assisted living facility that would cater to someone who's on the older side of the demographic that might need just a little bit of help, can't quite live independently, but can still live semi-independently if they have a little bit of supervision, a little bit of help maybe with their ADLs, or a little bit of help just managing their basic medical needs. Then you have some of your extended care facilities. Depending on the state, those assisted living facilities can have what's called an ECC license, and they can provide different levels of care that might be slightly more complex. Grouped into those assisted living facilities are sometimes your supportive living facilities and transitional living facilities. So your transitional living facilities are really facilities that go out there and specialize in the gap between acute care or subacute care and then transitioning the person to home. Once we've determined that someone's really reached their maximum level of function, we can move them to a transitional living facility that will help them learn the skills that they need to return to their home and to maximize what they're able to do at home. Also grouped inside of that extended care facilities are sometimes supportive living facilities. Think of supportive living facilities as facilities that cater to very specific diagnoses. Those specific diagnoses generally are TBIs and spinal cord injuries. A lot of times your TBI population will have behavioral issues and things like that. So those can be addressed in those facilities as well. And we'll touch on that on slides that are further down the deck here. Short-term acute care hospitals. Those are your small or large community hospital systems, your trauma centers. They're really designed to give immediate care, do surgery, and provide treatment across an entire spectrum. So they are your do everything hospitals. Patients can admit from all different environments, such as home, work, community, their place of injury. They can come off of, for us and my purposes, a lot of them are coming off of air transport from trauma and things like that. So really the short-term acute care hospital, their function is to get the person stabilized and ready to move to the next level of care. Basic length of stay is around the 3 to 5 days, but it does vary greatly depending on the injury. You get your burn patients and things like that, they're going to be there for a lot longer. Someone with multi-trauma, someone with limb loss and things like that might be there a little longer. Although limb loss, we're finding that the hospital portion of the stay ends up getting very short as technology progresses and things like that. As bleeding is controlled a lot quicker, access to facilities is a lot quicker, you end up with shorter hospital stays. Although with more severe trauma, you do have longer hospital stays. So your LTACs. LTACs are the long-term acute care hospitals. They are licensed as acute care hospitals, and they're typically used for patients who have prolonged and highly complex care needs. These patients are generally critically ill with complex conditions that require a lot of physician hands-on management and that require a lot of direct specialties. They're often providing ICU level care. So if you want to go by a Medicare definition, basically Medicare says anybody who hits 26 days should likely be transitioned to a long-term acute care hospital. For the purposes of work comp, that doesn't necessarily stand. We transfer the patient to the LTAC when it makes sense. So we deal with a lot of critical need and critical access hospitals that are really concerned with bed availability because they're serving underserved communities or they're serving entire regions, and they're the only specialty level hospital available out there. So oftentimes, as soon as that person is stable, they're getting them ready to go out there and transfer to an LTAC because those LTACs do provide ICU level care. There is some therapy that does occur in the facility, but the whole goal of that facility is to transfer the patient to the next level of care. It's improving them to a point where they can reach the required functional level to move on to the next level of care. So we have an example of a patient who, that's an example of my patient. He was in Florida and he was working in a field. His body temperature hit 109 degrees while he was working. We had a first success. First success was he managed to live. Second success was we managed to get him over to an LTAC. The LTAC was able to transfer him out to the inpatient rehab once he reached a Rancho level of 3, which meant he started to regain some responsiveness and consciousness. So once they were admitted to a specialty inpatient rehab program, they were able to maximize the amount of therapy that he got. And eventually we were able to transition him down the entire continuum of care, where he ended up living in a supportive living facility. But we always look at the LTACs as these are the places that we want to transfer the patient to get them out of the hospital. And then our next goal is stepping down the care so that they can get into a facility that offers a more intensive level of rehab. Although a lot of our LTACs are developing more high-end and high-grade rehab right now. So the way Medicare changed a lot of their reimbursement rules and things like that, it becomes very difficult to survive just offering LTAC levels of care. So many of our LTACs have invested a lot of money in developing their therapy programs and specialty programs. So they're really increasingly able to provide good levels of rehab and good levels of care. So sometimes the definition between LTAC and inpatient rehab hospital does get a little bit muddied and can vary greatly depending on what the facility is able to provide. As a general concept, these facilities are providing care for patients who require ongoing, highly skilled care, and highly skilled being the key. If they have complex wound care requirements or they have vent requirements, things like that, those are the type of thing that the LTAC is going to specialize in handling. Then we go to our inpatient rehab hospitals. Inpatient rehab hospitals are really one of the more common ones that are out there. They are licensed as acute care hospital. The key difference between what they are doing and what LTACs do is the intensive level of rehab they provide. Some inpatient rehab hospitals can provide a very, very acute level of care and take very sick patients, including patients on vents. The more acceptable standard is they don't always take the patients on vents. They take the patients that have come off the vent and they're ready for that intensive rehab provision. Many of these facilities have specialty certifications and have specialty programs to meet complex needs. They can be certified centers of excellence for strokes, for pulmonary, for brain injury, for burns, for spinal cord injury, for orthopedics. It means that they met a very high standard and they invested a significant amount of money in their programs, their equipment, and the training of their therapists. That's critically important. And it's really important to help improve the outcomes of patients. Not all facilities are created equal. Not all therapists are created equal. So matching the level of care to your facility is very important. Inpatient rehab hospitals care for patients who still require close medical supervision. They provide multidisciplinary intensive rehab programs, which typically include physical therapists, occupational, speech, respiratory. They can have dietitians. They have interdisciplinary physician teams that are there. Most inpatient rehab hospitals will have specialists in all different fields. So most of them will have a pulmonologist on staff. They will have a physician who specializes in burns, which oftentimes is a plastic surgeon, sometimes a vascular surgeon, depending on the area and the availability. They'll have neurologists on staff. They'll have all these people on staff to help manage these injured workers or to help manage these patients to really maximize the level of function. And their goal being maximizing function, restoring physical health and wellness, and returning the patients to the level of function and the level of safety where they can transition home or transition back into a work setting. So many of the patients that leave inpatient rehab hospitals will go out and potentially get home care, but a lot of times I find myself transitioning patients directly to outpatient care, especially when we're looking at your younger, more active population, patients that were in a little bit better shape and things like that. Sometimes we do a very short period of home health and then shift them to outpatient quicker, just because they can get a little bit more intensive rehab in outpatient versus home health. Patients typically participate in 3 hours a day, at least 5 days per week at these rehab facilities. That being said, therapy programs are individualized and they are based on the acuity and level of function of the injured worker or the patient. So many of these facilities have to follow Medicare regulations for their Medicare patients, which means they're delivering 3 hours of care a day. But when we look at our workers' comp patients, the great thing is those same requirements don't necessarily exist. I work with our inpatient rehab hospitals all the time, and I encourage them to deliver what's appropriate. When they're delivering the appropriate level of care, we can tell because we're getting the right levels of outcomes, we're getting the right goal achievement, and we're being conscious of the patient's overall condition. We'll take, for example, someone who might have dialysis. Well, a lot of these inpatient rehab hospitals can do dialysis inside of the hospital. So that can help maximize the participation in therapy. But anyone who's had experience with dialysis patients know that your dialysis patient, after a 3 or 4 hour chair time, they are wiped. They don't have the energy to necessarily do 3 hours of therapy a day. So oftentimes we find that the rehab hospitals will schedule the dialysis to maximize the therapy that the person can do, but they're also adjusting their level of therapy based on the person's energy level, because going through that dialysis every day or 3 days a week can be very zapping of their energy, essentially. So inpatient rehab hospitals really specialize in delivering all of that care. Your specialty care centers, they focus on providing care for specific populations. Generally, those populations are your brain injury and spinal cord injury. How they are licensed varies greatly from state to state. You'll find individual licensing specific to TBI and spinal cord centers in some states. At the same time, other states will say, well, they're licensed as a skilled nursing or they're licensed as an inpatient rehab hospital. Less likely being licensed as an inpatient rehab hospital, more likely to be licensed as a skilled nursing or as an assisted living with an ECC focus. These facilities are providing focused programming. And I can't tell you exactly what they look like because they look like 50 different things. So I walked into 55 different facilities last year to validate what their abilities are and that they could deliver the services they promise. And a lot of them were these specialty care centers. And I will tell you, they don't look the same from place to place. So they can be a private home, they can be a group home, they could be something right in your neighborhood and you don't even realize that it's occurring. They oftentimes are taking place in home type settings because they want to be able to transition the person eventually out of the facility and to a home. Or if it's a long-term living facility for them, they're trying to make it the most home-like environment they can. And being in a more commercial or industrial style environment where you feel like you're in a dorm or a healthcare facility isn't always best for the patient. It's not always best for their heads. I found a lot of them they've acquired apartment buildings. So I live outside of Atlanta, and we know that I do know that there's a few places inside of Atlanta that purchased entire apartment buildings. So they have the entire apartment building set up as residential rehab facilities. It's kind of a very neat function that they have, and it fits a very good market. And I don't think I've ever transferred anyone out of those facilities because they generally enjoy it. And these places specialize in setting up programs that are geared towards their population. Again, they can function as a permanent living setting or transitional living setting. They'll provide things like ADL assistance, transportation, behavioral health. And I think behavioral health is a huge portion of this in the supportive living, because you end up with a lot of traumatic brain injury patients who do have behavioral issues. And while they might have a willing and capable family at home, sometimes you just can't expose their children or others to what those behavioral issues are all the time. So we sometimes shift them to supportive living settings where there's professionals who are there that can handle them, that know how to manage their behavioral issues. And then the families can come visit, and then the children don't necessarily have to be exposed. I will say one of the big things that I have always tried to achieve is I try not to, with our injured workers, I try not to make their families and their children have some sort of chip on their shoulder against their family member that was injured. Like dad was injured and he has a traumatic brain injury and he doesn't love me anymore type thing because he says bad things. Well, we know that's not necessarily the case. We know that's a function of the traumatic brain injury. So having kids exposed to that all the time is sometimes very unhealthy for the kids. So we use supportive living facilities, these specialty care centers, a lot of times to create that separation. The families can still have a ton of contact, but there's at least a little buffer there. And if the patient's having a bad day, the kids don't have to be exposed to that. Transitional living settings, like I said before, it's really learning to live with the level of function that the patient has, and it maximizes their ability to participate in life and community based activities. Entry back into the real world, so to speak, can be very trying for injured workers. So we look at our traumatic brain injury patient, and maybe in the inpatient rehab setting, they have fake little stores set up to simulate what you would find at a Walmart grocery store or Target grocery store or something like that, and they plan activities for them to go and pick things to make a meal. Well, they can be successful at that, but then when you shift them to a real world setting, you go to like a Walmart or a Target, all of a sudden there's a whole different level of lighting, there's a whole different level of stimulation and noise and all of that going on, and they fail because it's overstimulation. It's overstimulating for them. And with brain injuries, there's a lot of delayed processing, things get backed up, and there's coping strategies that need to be put into place and activated to handle that overstimulation. So with our transitional living and supportive living facilities, they go out there and they purposely put people in those situations so they can identify what the issues are and then teach the people the coping strategies. So I find transitional living facilities to be of the utmost importance, especially working with traumatic brain injury patients, because you are able to identify these different triggers that someone might have. Skilled nursing facilities, they're not all old folks' homes, but they function as a subacute care option for patients who don't necessarily have as much of a clinical need or as complex of a requirement for rehab and care. There are long-term care facilities, average length of stay being 16 to 18 days for people who are admitted to the short-term rehab programs. SNFs usually exist within nursing homes. There's often not much of a definition there, but you go inside and they'll have a rehab wing and a long-term wing. They're the same facility, the same licensing, everything like that. So your nursing home is typically dealing with custodial care where it's non-skilled. I don't mean to say that the people providing the care are not skilled, but it's more focused on ADLs, bathing, dressing, eating, general mobility, and not focused on rehab. Typically, they're used for patients that don't necessarily require your 24-hour physician monitoring. The therapy goals might not be as intensive, or they might function as a gap facility for somebody. I will say that my more common utilization of a skilled nursing facility often falls in line with injured workers who have a weight bearing restriction and are simply unable to return home because of it. Let's say someone lives in a second floor walk up and they have a non weight bearing because of a tibial plateau fracture. We might run them through inpatient rehab. They maximize their level of function. They still might be non weight bearing for another maybe 6 weeks or so. And we'll often put them into a skilled nursing facility. They'll get taken care of. They'll have an hour of therapy or so a day. And that'll really just serve as a gap and a holding place for them before they can safely return home. Of course, you can get someone into their home. That's usually not that big of an issue, but our concern is being able to get them out should there be an emergency, or get them out if there's actually appointments for them to go to and things like that. So a lot of times the skilled nursing facilities serve a purpose, and that purpose oftentimes can be as a holding facility where they do get some actual care and rehab. Assisted living facilities and extended care facilities, they're typically providing a place to live. They're generally long term. The patients do not require around the clock supervision by medical personnel, although most of them will have a nurse 24 hours, but that nurse will be, one for potentially 100 plus residents. They generally have a bunch of home health, not home health aides, certified nursing assistants, or personal care assistants that can help people out. These facilities are considered the patient's home or residence. They're generally not transitional, but it can sometimes include transitional, just depends on their licensing. Oftentimes, the patients require slightly elevated levels of care, and that care might be provided by skilled nursing, or by nurses in the home health or outpatient type facilities. So a lot of times your assisted living might have someone who, let's just say they have a little decline, because we know with our older folks, they get a UTI and that causes them to decline. Maybe they need some therapy, maybe they need some better med management. Physician will write an order for home health, and that home health can occur inside the assisted living facility, because that assisted living facility is the person's residence or home. And generally, they are on a more permanent basis, but some do have transitional living involved, where it might just be they're stabilizing another environment for them, or they're going to get maybe move from a multi-story house to a single-story house, but it takes the family time to coordinate that. You might put them in an assisted living facility because that's going to be the better environment for them versus having to navigate stairs. So this is just a graph that really details out the similarities and differences between the facilities. They're all licensed. They all have physician involvement, but your LTACs and your inpatient rehab hospitals typically have daily physician involvement, where your skilled nursing facilities oftentimes use physician extenders. So nurse practitioners, physician's assistants, things like that. They do visit frequently, but not daily. All of them have 24-hour nursing, but they have different capabilities. So your long-term acute care hospitals and your inpatient rehabs generally have pharmacies on site. That makes a big difference. So being able to do pharmacy on site, being able to do labs on site allows them to be much more responsive to things. They'll generally have procedure rooms as well. So minor procedures don't involve transporting to the hospital or going to a surgical center. So let's just say someone needs a PEG placed or something like that. PEG can be placed inside of these facilities because they do have procedure rooms, which are basically like little ORs that are in there. And the physicians that are attending are fully within their scope to do the minor surgical procedures there. All of them offer interdisciplinary treatment approaches. LTACs and inpatient rehabs are a bit more intense. They definitely focus on physician-led conferences with a high participation of therapy and therapy staff to help write out the plan and help dictate what's going to go on. Ancillary services, like I said, pharmacy, lab, procedure room, radiology, all of that is generally present in the LTACs and inpatient rehabs. In the SNFs, they're available, but it's generally not on site. A lot of times they're coming in from off-site. And why does having a pharmacy matter? Having a pharmacy matters internally because a physician can make a medication change, and that medication change can be done almost immediately. A lot of the pharmacies, the physician will know what the pharmacy stocks in-house, or they'll have a list, and they can pivot to different medications or different strengths versus having to order out, which most facilities, even your skilled nursing facilities, have the ability to order out, but there can be a couple hour delay getting medications in. So your LTACs and your IPRs have the ability to do that very quickly. And generally, your patients who are at your skilled nursing facilities are way more medically stable than your patients that are at your inpatient rehabs and LTACs. Um, Although your unstable patient will generally be residing in your LTAC, a lot of inpatient rehabs have patients with questionable stability as well. So anybody who's got higher medical complication belongs in one of those higher skilled settings. It helps reduce the readmits to the hospital. There's way more one-on-one care. There's a lot more rehab that's offered as well. So when we look at rehab, your skilled nursing facility will average an hour a day. Your inpatient rehabs will average 3 hours a day, at least 5 days a week, although most of them do it more. And then your LTACs will offer on average 45 minutes. Although, as I stated earlier, that is changing because the reimbursement models have changed greatly and have forced LTACs to go out there and expand their offerings. So right place at the right time. That's what I like to tell people what's appropriate. When they ask me what's the appropriate care for the patient, it is very much based on the snapshot in time that we see today. So understanding the level of care and how choosing the right level of care really does impact patient progression. Outcomes are very much dependent on the placement and their correct level of care, the timing of the interventions that are selected, the selected interventions themselves greatly influence recovery. Rehab services do get delivered in a variety of settings at different levels, but we have to make sure that the specialty that the facility is able to provide is able to meet the injured worker's needs. That's key. When we look at LTACs and inpatient rehabs, there's a variety of different center of excellence designations that can vary between the two. They can be called a COE, a center of excellence, a gold seal, a certified, whatever. It just depends upon their different levels that they offer and their different certifying bodies. These COE designations are issued by the different accrediting bodies, and they give you an amount of assurance that this facility knows how to handle this type of patient. That being said, any LTAC or inpatient rehab facility can offer a good quality of rehab that will address all types of injuries. But when we're looking at getting the best outcome, we look at driving to facilities that can offer the best levels of care, which means the best level of specialization. So we're constantly looking at what the level of care, what their skill sets are, and does their skill set actually match what the injured worker needs. So in the acute rehab setting, having highly skilled rehab is very important to facilitating recovery, maximizing the effect of the emergency services they've received, maximizing the impact of the surgery, preventing complications, and really assuring that the optimal outcomes are achieved. Acute rehab hospitals, inpatient rehab hospitals are really set up for patients that require daily care, that require daily physician management, and that are there for medical recovery and intensive rehab. Acuity matters. Rehab in the community, while it aims to optimize function in those who are not in the hospital system, doesn't necessarily drive what's appropriate. Lower level patients might do fine with home health care. We oftentimes get an argument with injured workers where they say, I don't want to go to an inpatient rehab hospital. I want to go home. I can get home health. Home health provides on average 2 to 3 PT visits per week. Those visits will realistically be between 45 minutes or an hour max. So now you've got a total of 2 hours and 15 minutes to 3 hours of rehab per week, with only 3 days per week of interaction, with a limited amount of equipment, because the amount of equipment that the person will have access to really is dependent upon what the therapist can carry in the trunk of their car, which isn't much, to be honest. Your inpatient rehab hospital is going to take that same patient and they're going to offer them 15 plus hours of therapy per week, 5 to 6 days, or 15 plus hours of therapy per week over 5 to 6 days. you're looking at 5 times the amount of rehab that someone would get at home. Acuity matters. If the patient's in need of rehab, or they're even on the fence of whether they're going to need inpatient rehab hospital or not, we try to err on the side of being more cautious and say, yes, let's put them in the rehab hospital, even if it's only for a few days, and even if it just validates that, okay, the person is safe enough to go home. Safety being one of the big considerations here. Patients go home, and if they were on the fence of, are they going to a rehab hospital or are they going to go home, there's probably a safety concern that's there. So really consider their level of acuity requires a inpatient rehab hospital. So discharging them to home puts them at a significant safety risk, and it puts them at a risk of readmission. And not all people are going to require inpatient rehab. I have plenty of patients who fall and break a hip that can go home just fine. Just depends on the living setting that they're in, the amount of help that's available at home, and their own personal physical condition. So there is a huge impact on outcomes. Attention really needs to be given to systems that are delivering the appropriate care, they're utilizing the appropriate staff, that are providing the appropriate services on site, and that are offering therapy and interventions that are really evidence-based versus therapy interventions that someone's just providing because they've been doing it for a long time. Not all facilities are created equal. So that is one of the big things. Just because it says inpatient rehab hospital on the outside does not mean that they're able to provide the same care as one that's a block or two down the road. So the road really starts in the pre-admission time, screening at the hospital, determining what the patient actually needs, reviewing and determining what facility is going to be appropriate. And that facility is going to review the case, and they're going to have it run through their IDT, and they're going to establish treatment plan and goals. So after the admission, there's going to be an evaluation of the patient's progression over time. Based on the newer evaluations that occur in the facility, they're going to go out and they're going to address the patient's physical needs, cognitive needs, emotional needs, social barriers. They're going to start discharge planning almost immediately. So that discharge planning is important because getting things done like home modifications or something like that, if access is going to be difficult to the home, is something that takes time. These things can't be done overnight. So it's important to get the person into a facility or type of facility that's out there and being proactive and thinking, hey, this person might be here for 2 or 3 weeks, but what are we going to do after that? So really with the discharge planning, we're going out and we're assessing the ongoing needs of the patient. So everyone asks what kind of diagnoses generally go to inpatient rehab facilities or acute rehab facilities. Your strokes, your spinal cord injuries, ortho trauma, amputations, things like that, major multiple traumas, simple hip fractures. Believe it or not, a lot of people have issues. They have the trauma of falling, fracture a hip, and either do a hip replacement or an ORIF on their hip. For a lot of people, that can be difficult. For someone who's really in shape and stuff like that, maybe not. But considering a significant portion of our population is a little bit overweight, believe it or not, that can cause a lot of complications and necessitate rehab. It's usually not long rehab. It's usually only a handful of days, but it helps them turn the corner and get a little bit more confident and become safer. Brain injuries come in all different types and all different sizes, essentially. You know, mild brain injuries where it's going to be better to get them back home and get them on with neuropsych to help heal that brain. At the same time, you have major ones where it's just not going to be getting them home immediately isn't going to be in the cards. You know, getting them specialized rehab is going to be necessary. Neurologic disorders at the same time. Some neurologic disorders require inpatient rehab. Sometimes, you know, it just be an exacerbation. Someone could have had an injury a long time ago, but could have an exacerbation of a neurologic disorder. Burns, yeah, burns almost always require, burns over 5% usually end up requiring some amount of inpatient rehab. And we look at them and say, wow, why does a burn impact their ability to function? Yeah, you know, Doesn't necessarily always impact their ability to walk, but think about the inpatient rehab as it's a controlled environment. I did home care for years, and walking into a lot of the homes, it's not someplace I would want someone with a very large open wound, which is essentially what a burn is. So sometimes getting them in the rehab environment is just a cleaner place for them to be. Capabilities of LTACs, we've really already gone over this. It involves daily assessments, 24/7 care, respiratory is always on site, prevalence of PTOT and speech services, pharmacy, dialysis is available on site. Increasingly with portable dialysis systems like Tableaus and things like that, it's hard for me to find facilities now that don't offer in-house dialysis to some extent. In-house dialysis saves on scheduling headaches, transportation costs, things like that. You know, sometimes they have dialysis suites where they're just wheeling the patient down to that suite, so there's no transportation issue. A lot of times, if it's a Tableau system, they just wheel it right on into the room and hook it up, and they can get dialysis right there in their own bed, and comfort and family can be there and things like that. Dietary and nutritional management, yeah, that's actually really important. Something people don't necessarily consider often is healing requires an increased presence of certain nutrients. You take someone who's got burns, and you need to jack up their protein intake and things like that because they're consuming a lot of protein, and you don't want to get to a point where they're going to start breaking down muscle tissue to access protein. You want to provide enough to their body, which might actually involve using TPN or something like that. And that's what our facilities can do. Some skilled nursing rehab facilities can do TPN. A lot of them just shy away from it and leave them in the inpatient rehab hospitals or LTACs. There really is a team-focused approach. So PM&R physicians really are going to be the ones who specialize in treating those physical conditions and things that impact the brain, the nerves, spinal cord, bones, joints, muscles, all that stuff. So in our rehab hospitals, you do have PM&R physicians, and they're all over the place. So they're the ones that are going to kind of take a holistic look at everything. You have your internal medicine physicians, which they're going to generally monitor the basic medical issues that are possibly being exacerbated by a debilitating condition. Let's just say someone's getting cortisone or something like that for their for whatever injury they have, or they're getting steroids or something like that. We know that, okay, if someone has diabetes or has a tendency to run pre-diabetic, that getting those medications can push them into having issues with their blood sugar. So your internal med physician will be monitoring things like that. Consulting physicians, yeah, they're going to have consulting physicians in every specialty. That's of key importance because you don't have to ship out to the hospital. A lot of things can get addressed and recognized before they become an issue. The nurses are trained in rehab. These are not nurses who are doing home health, every day and then picking up a little side job of doing, nursing home hours and things like that. These are nurses that are specifically trained in rehab, and oftentimes they're familiar with the physician's protocols. So let's say we have someone in a facility that offers burn care. A lot of times those nurses are trained directly in the burn care that those are the burn protocols that the physicians have. Of course, you have your OTs, you have your PTs, you have your speech language pathologists. Your OTs are really helping you regain some of the function and the more fundamental physical function. Like a therapist will teach you to raise your arm back up over your head. The occupational therapist will teach you what to do with that. So, the PT gives you the ability to raise that arm, and the OT kind of teaches you how to brush your hair, comb your teeth, or brush your hair, brush your teeth, things like that. So speech language pathologists are often out there addressing speech issues, swallowing issues, things like that. What people don't realize is they often address a lot of the cognitive issues that come along with injuries as well. Respiratory therapy, being there 24/7 to deliver care, is very important. You have respiratory issues, you start a cascading effect that causes a lot of problems with patients and will cause a quick readmission to a hospital. When you have respiratory therapy available on site and easy access, you can oftentimes stop that readmission process because they can go in and manage it. Then you have your case managers that are in there, and they really should be focused on that next step, that next level. How do we get these folks home? So the inpatient rehabs, again, they focus on creating specialty programs that address your brain injury, spinal cord injuries, and all the other specialties. They should have certifications and designations that go along with it to help support the recovery of the patient and help validate that they can provide the care that they're promising. So brain injury patients, quick stats on brain injuries. 64 million adults in our country report having a TBI at least some point in their life. People say, oh, I got my bell rung. Oh, I got a concussion. And, they think that wasn't a traumatic brain injury. That is a traumatic brain injury. So there's 2.9 million ER visits per year due to TBIs, which means someone's hit their head hard enough that they felt it was necessary to go to the ER. 190 people die per day from TBIs, although TBI survivability has increased dramatically in recent years. So hypovolemic death is much less common, and that often comes along with TBIs. Hypovolemic death is basically blood loss. So how is that decreased significantly? Well, there's things like one-to-one transfusion protocols, different blood byproducts, things like that. Quick access to medical care. I think something funny, people laugh when I say Starlink. Starlink has been a big factor in increasing survivability, and people say, why Starlink? That's because it gives quick and cheap access to physicians. So you've got a trauma team that's out in the field addressing someone who's just had let's say a motor vehicle accident, and because they have fast internet connection available to them anywhere, essentially, they're able to get on the phone and do live video with a trauma physician who's in the hospital, so the trauma physician can better guide them. So things like that are big. And why is that important? Well, survivability is always good, but now with survivability comes the responsibility to care for people who have survived the brain injury. So more than 50% of adults who had a brain injury at the time of their working, 5 years after, they're no longer able to work. And that's significant. And doesn't mean that, that the TBI was so severe that it caused them to stop working immediately, but it can be things like persistent headaches, intolerance to lighting, intolerance to noise or stimulus in environment. All of those things have a big impact on, being able to work, being able to hold a job, which might sound funny, but it's a reality. So someone works in an office environment with bright lights and lots of noise going on, and they have a TBI and they have any sensitivity to things, that can pose a problem. Age does matter with these TBIs as well. And tolerance to blood loss. You get a lot of older folks, a lot of them happen to be on anticoagulants. When someone's using anticoagulants, moderate blood loss becomes a major issue very quickly because they are having, because they're essentially having issues stopping the bleeding. So what's a minor blood loss to someone who's not on an anticoagulant with someone who is on one becomes major. Delayed access to hospitals and things like that as well, and delaying implementation of blood loss control and massive transfusion protocols will also reduce recovery and things like that. So the approach really does matter with these. You have to have interdisciplinary teams. That's why it's important to have specialization, these specialized locations and places that offer specialized levels of care and offer centers of excellence for traumatic brain injuries. They really do provide the modalities and the exercise along with the pharmacologic intervention and cognitive function protocols that will help aid the patient in their ability to recover and to go home. So they offer a lot of community integration, and they tailor programs to really meet the occupational goals of the injured worker as well. These TBI programs are not bulk programs. They're not people working in groups all the time. It's very much one-on-one. They utilize advanced equipment and technology really designed to support the recovery, like motor function. The technology that's out there, especially with computers and AI and everything like that, it's actually amazing. So they can also assist patients with adaptive changes that they might need during their recovery. So how much you're going to access these services is likely dependent upon the insurers that you're working for. If you have carriers that are insuring high risk occupations such as construction, you're going to see this more versus carriers that are insuring groups that are more sedentary, like office workers and things like that. So, yeah, I mean, sometimes it's just not going to be seen very often, but then in other settings, you'll see it a lot. So, neuropsychology is hugely important. Neuropsychology, the best way I can define it is it's healing the brain. So, it's going out there and it's saying, okay, this is what's required for the body to process and for the nervous system to interact with the environment. It influences behavior, cognition, and really neuropsych is addressing the dysfunction that occurs in the brain and doesn't allow people to process. It is one of our largest growing fields, and when I look at TBI programs and I look at specialty programs, the presence of an on-site neuropsychologist that most places don't have them full time, but some do. The presence of neuropsych is huge. I can tell you that neuropsych is something that's difficult to access. You have example, San Antonio, the greater San Antonio addressable market is about 800,000 people. They currently have 2 neuropsychologists in the area, and one of them's retiring. So to show how rare and how specialized the service is, I mean, you're gonna have 800,000 people trying to access one neuropsychologist. So that's it just shows that it is necessary, but it's something that not a lot of people are getting into. It's not quite as understood. You can't always see TBIs. So that's one of the things that's very interesting is people will say, oh, there's nothing wrong with them. Well, just because they can walk and talk doesn't mean there's nothing wrong with them. You can't see a traumatic brain injury a lot of times. Spinal cord injuries, they can vary greatly depending on the level and extent of the injury. You can have partial injuries, full injuries, things like that. Using equipment like exoskeletons, Ondago robotic systems, things like that, they really get the person's limbs moving and help and really help with recovery. Specialized spinal cord facilities have programs that assist with aphasia, cognitive delay, seating positioning, bowel and bladder training, all of which is of the utmost importance. Bowel and bladder training, if they don't, seating and posturing, bowel and bladder training, things like that. If that's not done right, you end up with a lot of breakdown on the person's skin, which causes a lot of other issues and can ultimately lead to death. So managing that, although it might not sound that important, it is really important. They specialize in neuro recovery and counseling, counseling being a huge thing. You know, addressing the psychiatric impact of losing function in your body is huge. They provide emotional support. They provide DME support and things like that. Rehab for multi-trauma patients. At that point, it's about providing a well-rounded rehab program. It's providing an interdisciplinary team that basically includes all of your specialties. It can include cardiology, infectious disease, GI, plastics, all of that needs to be present to provide the level of care required for multi-trauma patients. They're usually not just one injury, they have multiple injuries that need to be addressed. So, you know, they can provide specialized therapy, or I should say they need to provide specialized therapy that's going to address the cognitive function, improve communication, improve orientation to home, and help with attention and memory skills. Amputee rehab, in the workers' comp space, 80% of our amputations are above our upper extremity, 20% are lower extremity. It's important to have a facility and a prosthetist that specializes in upper extremities because they are much more quirky and less forgiving than lower extremities. Therapy provided by the team really is going to be based on compensatory techniques, using appropriate equipment, learning how to adjust the equipment and learning how to function with the new equipment. Uh, it's really important to track the patient's needs, goals, objectives, things like that. Well, it's nice to hand someone the most high-tech device on the planet. A lot of times, having the most high-tech devices can be very frustrating to patients. So sometimes having them crawl with a more basic device before we make them go into a full-on run with a complex device is going to be ideal. Believe it or not, as we get into more advanced technology with rehab, their hospital or with prosthetics, their hospital stays shortened, but their rehab length often lengthens because they need to be trained with things like implants and stuff like that that will go into the muscles, neurologic implants, things like that. That all requires specialized skills, targeted muscle reinnervation, things like that. It all requires specialized rehab. So sometimes they'll get out of the hospital quick, but have to spend a little bit longer in rehab to maximize those the effect of the surgeries that were done. Respiratory programs. So a patient that can't breathe ends up going into a panic. And like I said, it's a cascading effect. That cascading effect often results in the patient going back to the hospital for unnecessary things. Most respiratory facilities with respiratory specialties and pulmonary specialties, they're able to go provide stress tests. They can measure oxygen levels, blood pressure, heart rate, all of that during exercise. So they can really build programs that are geared towards reducing shortness of breath, increasing energy levels, and maximizing level of function. So really, they have to increase the person's lung capacity and increase their ability to participate in activities because, again, it's a cascading effect. Difficulty breathing can start causing panic and things like that, and it's your quickest way to a hospital readmission. Specialized wound care requires individualized treatment plans and physicians who actually know what they're doing with wound care, not physicians that are stuck in doing traditional wound care that's been around for 25 years. You need to look at physicians that are open to, debridement, which is old, but compressive therapy, vac therapy, specialized wound care, including amniotic grafts, biotics, things like that. Those are all things that need to be addressed by a wound care physician. So when they're unwilling to address them, it's very frustrating because they're just prolonging the recovery period and things like that. Like you use an amniotic graft, you use the right graft, you can heal a wound that would require 6 to 8 months to heal. You can heal it in 6 to 8 weeks. There's a cost associated with it, but it can be done. Why does technology matter? Advanced tech and rehab really helps improve circulation, helps improve function, helps improve coordination, reduces pain, can simulate real-world driving and shopping, provides sensory training, can help with balance and fall prevention. Tech matters. Newer and more advanced systems are really able to, I can put the patient's name in on day one when they're admitted to the rehab facility, and I can track them over time to make sure they're able to make sure they're actually able to progress over time. So I do realize we're running out of time. I will wrap up very quickly here. So this is what an inpatient rehab hospital should look like. Large private rooms, gyms that are well equipped, kitchens for ADL training, multidisciplinary teams, just wide open and accessible to the patient, an environment that's encouraging participation. Programs aren't created equal. Programs should be focused on, these are my case studies, but programs really should be focused on return to work, pain control, things like that. Whatever is going to get the injured worker back to work or get them closest to being able to return to work is what the rehab facility should focus on. So that is all. I will end the presentation now because again, it's just case studies now.
Well, thank you, Jeff, so very much. We can have a couple minutes if you have a couple questions or so. We'll take 2 or 3 minutes for questions if you have any. If you don't, then we can wrap it up for you. I don't see any well, let's see here. We do. Post-concussive syndrome.
So
And
post-concussive syndrome is one that's really interesting. So there's increasing number of concussion-based programs out there. It's not something that a lot of carriers take seriously, and a lot of physicians don't take seriously as well. So that's actually something that's really hard to get people to agree to. I have a lot of TBI and neuropsych facilities that do focus on that post-concussive syndrome, but it's hard to sell. I started presenting on concussion based therapy probably in 2020, 2019, somewhere in there. And people would kind of roll their eyes at me because they don't believe it's something that exists. It really does exist. It impacts focus and people's ability to go out there and work and function. Concussions also increase the likelihood of major traumatic brain injuries occurring on a secondary injury. So a construction worker that gets whacked in the head today and has a concussion that's a traumatic brain injury. There's swelling in there. There's things going on, and their brain has less ability to compensate when they get hit, 2 or 3 days or a week later. So happens with athletes. Happened with there was a professional snowboarder, and he got what should be he got a concussion. He had a secondary fall 2 days later, which was a very mild fall, but ended up with a major traumatic brain injury because of it, because there was already swelling present. So people who have concussions, getting them into post-concussive programs or concussive syndrome programs, I mean, I'm a huge supporter of that. They make great progress. It's a great place for neuropsych. It's a great place for speech therapy to all go in there and participate and help minimize symptoms and minimize the impact that it will have.
well, thank you for answering that question, Jeff. We certainly appreciate it. We know that we've taken up a little bit more than an hour of your time, but I do want to thank everybody for joining us. We know you have a lot on your desk, and we know you have a lot to do. And we appreciate that you took the time out of your very busy day to spend it with us. And thank you again. Your certificate may arrive before 2 hours. If you have any questions, Wendy at macropro.com. Go ahead and shoot me a question if you have them, and we can make sure that Jeff gets the information. So everybody have a great weekend and enjoy your summer. And Darcy and Jeff, if you will go ahead and
thank you, Wendy, for having us.
Yeah, thank you so much for joining us.
Thank you, everybody.
If you have any questions, reach out to me.
Let's see here. Sometimes it takes a second to. There we go. Just a couple seconds for people to be logging off. Jeff, we have your information in our materials
Great
tab, and it has, I think it has your contact information as well.
Okay.
And then once I get the full and complete attendee list, we'll go ahead and make sure to see if there's any questions, and then